my definition of success is embracing like the hustle and grind for whatever it is your goal is. All right, guys, it is an incredible honor to have Dr. Aniqa Gorgani here with me today. She's a primary care doctor out here in Long Island. I believe you practice in Suffolk County, correct?
Yeah, I practice in Green Lawn. So we just moved from Park Avenue in Huntington to a new office in Cuba Hill in Green Lawn. And I work for Mount Sinai Doctors of Long Island. And I'm a family physician.
Well, it's always good to have a fellow Mount Sinai doctor in the house. As you know, I'm an attending at Sinai in the city at the mothership. So
yes.
It's a real pleasure to have you here.
Thank you for having me. I'm so honored to be here with you.
Well, it's a love fest. We're going to get into some heavy stuff today. So one of Dr. Gorgani's passions is obviously helping her patients as much as she can. She has a very sort of broad view in what that encompasses. I'm including screening patients for domestic violence issues, which is such an incredibly relevant topic. I mean, it always has been, but particularly just with the political climate, I don't think I really need to dive into it. And just, all the stuff that's been in the news with like the Harvey Weinstein stuff, and it's extraordinarily relevant, and we're going to dive into it. But before we do, I just want my audience and me to learn a little bit about the person you are and what kind of drove you into medicine. So I like to start way back. So let's just start with, where you grew up.
Sure. Yeah. I actually grew up in Long Island. I was born in Coney Island, where, most Pakistanis were born in Brooklyn. And my parents were immigrants. They wanted to live that, immigrant dream, I guess it is, the American dream. And we moved to Long Island when I was around 5 years old, and I started school at kindergarten in Jericho. So I went to Jericho and graduated from there. And then I went to Stony Brook for undergrad, and I went to Ross University for medical school, which is in the Caribbean. And it was, it was hard going away, being away from your family and everything. But, I survived the island. That's the terminology that we use. And then I ended up going to residency in the Bronx, Lebanon, where I did my family medicine residency for 3 years. And I then got a job at Mount Sinai. And in between all that, got married, had 2 kids, and, just trying to balance that mom doctor life. It's hard.
That is no easy task.
Yeah.
It's amazing. Our stories are like pretty parallel. My mom came over. I lived in Brooklyn till I was 5, and then I moved to Long Island.
There we go.
I grew up on the South Shore of Long Island, but my kids go to Jericho School, where you went. So yeah, I lived locally. So
that's so cool.
It's a really kind of small world. Our worlds really intersect.
Yeah, they did. And then I met you.
That's it. And the rest is history.
The rest is history.
Were your parents physicians? Did they come here to practice medicine?
No. My parents are not physicians. My dad was a lawyer back in Pakistan, but when he came here, back in the 80s, your education wherever you were brought up outside America, it wasn't really recognized like that. So my dad, he worked in mostly accounting and that kind of thing, and now he does like insurances. And my mom, she was not a physician as well, and she works with children with disabilities now. She helps out with kids and disabilities. So they both were passionate for me to become a physician. And what's funny is that I don't remember.
Classic East Asian.
Yeah, I mean, I actually never had any other dreams, though. I actually wanted to be a doctor. I still remember when I was in, I think, 2nd or 1st grade, and the 5th graders came up to us and they made everyone say, "What do you want to be when you grow up?" And I said I wanted to be a doctor. And it's even in my 5th grade yearbook.
There you go.
It says future doctor. So, I always wanted to be in primary care. I really find that relationship that you have with your physician is so important. And I think, and that's another reason why this topic is important, because you need to build that, not just rapport, but that trusting relationship really with someone you trust. And when it comes to my patients, I do see that they come to me and they open up about everything. I have a box of tissues in my room because the amount of people that come in with different, whatever the issue may be, whether it's, their parent is dying or they have an issue with their husband or child, they open up to their primary care. So primary care is extremely important, especially now. I feel like with everything that's going on in the world, you need someone you can just go to and talk to. Sometimes I just talk to my patients about what's going on in their life, and the medicine is even not there in that visit. And that's something that I always felt like I would be good at. I would be good at developing that relationship, and that's why I chose primary care. What's funny is my mom, she's a part of UPNA. I'm not sure if you know what UPNA is. UPNA is basically the alliance of physicians from Pakistan. So she's
it's like API for same sort of thing,
right? Yeah. So she's kind of like a guest member, and a lot of her friends are physicians, and they work 7 on, 7 off, hospitalists, and they love their job. And my mom was like, "Why don't you do that?" And I was like, "Yeah, Mom, I'm sure the lifestyle is better. You get 7 days off, but that's just not my passion. And I want to do something I'm passionate about. And that is really getting to know people and knowing what is affecting their health and what I can do on more of a personal level to help with their health." And I think I have been helping my patients in that level. And I'm excited to move forward with my career in doing that.
Well, I mean, you seem like such an incredibly easy person to talk to, and you're so like warm and inviting. Yeah. I can imagine your patients like immediately develop a great rapport with you.
Yeah.
It's interesting. In my New York City office, there are 2 primary care doctors that work directly across from me in the office that's across the hall. Mm-hmm. It's the same sort of deal. Like one of the doctors, his name is Jerry Clements. He sees entire families, and he's been seeing them he must be, he's in his 50s now, or maybe a little bit older, but he's been seeing like patients for like 20 years. So he started out seeing somebody, then he started seeing their husband or wife, then he started seeing their kids as well. An entire family see him, and like, God, that's like such an incredibly special thing.
Yeah, it is.
Because not only like, is it so cool taking care of families, but like you've seen these families form, and you kind of know the ins and outs of each member of the family individually.
So true.
And to be able to sort of triage issues. And you're right, being a doctor is so much more than, hey, like for me, hey, I have this rash and, can you help me, or whatever, I've got sniffles, or, my stomach hurts. It's knowing your patient and like, having the human relationship with them, like that's what being a doctor is, like
absolutely.
Like otherwise you're kind of just like a clinician,
I know what you mean.
But being a doctor to me means so much more, and then what you said just really captures that so beautifully.
Yeah, I 100% agree with you. And to your point, I think the best compliment I get is when women bring their husbands to me.
Right.
And they're like, "You know what? I want you to be my husband's doctor." To me, that they look past, me being a female physician and really just being someone that they trust. And I actually see adolescents as well. I see adolescents, and recently I actually even picked up another shift at my clinic, and I'm helping just temporarily with pediatrics.
Oh wow!
So it's just like an acute visit thing. I'm not, I'm not a pediatrician, but I do help with the acute visits for now. So I really do see adolescents too. I have a 100-year-old patient. I have a 96-year-old patient. I see. You're right. Like I see the teenagers, the 20-year-olds, the 30-year-olds, their parents, and then their parents. And and I always get really close to the people that bring their family members to me, because it just shows how much they trust me, not just my medical advice, but just trusting my opinion in general. So, primary care for me it's not a job. It's almost a lifestyle, and it was my calling, and I'm really glad I'm in it.
I'm glad you're in it too. I'm sure your patients are glad too. I mean, you really practice family medicine.
I do.
It's not a lot of family med doctors now will focus on just internal medicine for the most part.
Yeah.
But it's really rare for me to really see a family medicine specialist.
You're right. It's not that common, especially in New York, given that there's the specialties out there with pediatrics, GYN, internal medicine. And I think that, so the department I work in an internal medicine department, and I'm the only one that's seeing 15-year-olds. Wow. So it is different as a family physician, and I'm open. I mean, I'm not seeing GYN right now. However, I would be open to it, and I've talked to my OB colleagues that maybe if they needed some help here and there, I could, assist them. So it's actually a great field, and I'm so lucky to be in it. I feel lucky to be in that field.
Well, that's why you're so good at it. So I'm going way back here, like 20 years when I was doing my family med rotation or internal medicine rotation. I know a big part of preventive medicine, or a big part of internal medicine or family medicine is preventive medicine, preventive care. So that with that, there are tons of different screening tests and like guidelines that you have to follow, like get your colonoscopy at such and such age, and mammogram should happen at such and such age,
right.
and yearly skin cancer screenings,
yes.
for those that need them.
Refer to you.
Included with that are, going by memory, there's like a cognitive assessment as you're getting older, like sort of the dementia tests that you do, depression screenings. So now with the way things are kind of going with, all the stuff that's been in the news lately, one of the things that you mentioned to me that's really being pushed, it sounds like even in the meetings and stuff, is domestic violence screening and, that wasn't really going on when I was a medical student 20 years ago. So I think would you say that's something that's more novel or sort of a newer screening thing that's happening?
Absolutely. I'm not sure if you know, but October is Domestic Violence Awareness Month. And October of 2018, so last month, there was a new guideline that was published by the United States Preventive Services Task Force, otherwise known as the USPSTF. And that is basically clinicians are recommended to screen women of childbearing age up until their 40s for intimate partner violence. And I think it's a huge, huge thing because I'm not sure if clinicians in the past really were screening. I'm sure they have been. I'm sure that people ask, how are you? Do you feel safe? That kind of thing.
Sorry to cut you off. I remember like in the pediatric rotation,
right?
You'd obviously screen for child abuse. And even when you were doing an emergency medicine rotation, like those sorts of things. So I guess this is sort of like an extension.
It is an extension of it. Absolutely. You're absolutely correct. So child maltreatment is a part of that task force as well. And that is a part of pediatrics and screening purposes. And I'm not sure if I'm sure actually, we all have to, when we get our license in New York State, you do that CPS course. Every one of us has to do it. Nurses, I think teachers have to do it. Police officers have to do it. Physicians do it. And even childcare workers. So New York State mandates any one of those professions to report child abuse. I did not find in my research any mandates on other kind of abuse when it comes to adult or elderly. However, we do have to obviously report if there's some kind of maltreatment when it comes to anything kind of guns or knives. That is obvious. You report that to police. But when it comes to anyone over the age of 18, there's no mandates. However, with this new guideline, I think it will start with medical students. Now medical students will now be trained with this new guideline in place, right? That when you have that opportunity, you have a 30-minute appointment with the patient, you have a physical, or you have a 15-minute follow-up, or even the dermatologist, that gets to see a patient and they see something. Do they raise the red flag? It should be raised. We should be asking people, do you feel safe? And it is important. And I know that I have been implementing it. I know my practice.
So is that the question you're asking your patients? Like what?
So
for us, like who are kind of, you're really on the front line, but as someone who sees patients as well.
Yeah.
What do you say? Like, how do you?
For other physicians?
Yeah, like what do you ask your patients?
I think it's an easy question to ask. I think it's a question where you could basically say, how's everything at home? How are you doing with your husband? How's everything? You feeling, everything's okay? And you know what? You'll get that sense because the point of this guideline isn't for obvious signs. It's for non-obvious signs. It's to find a positive response in that non-obvious sign. we are not going to know if someone's being abused if they don't have any physical symptoms that you see. But there's so much and so many other types of abuse.
Right.
And whether, and that's the topic I really wanted to speak about, was not just physical abuse that you could see, it's the mental abuse that can cause.
Can you go over like some of that
Yeah,
stuff?
sure. So basically, what the term is intimate partner violence. That's the main guideline that came out. It's about intimate partner violence. So what's an intimate partner? It could be anyone that you've dated, anyone that you've had any kind of relationship with, whether it's a spouse, a girlfriend, a boyfriend, someone you casually had a relationship with, a fling, a hookup. People go on, what's going on in the world right now, the kind of relationships,
Tinder dates,
Tinder, whatever it is. And any one of those relationships, any kind of intimate relationship that you can have is the kind of thing that we're looking for. That is there any violence or any kind of abuse in any of those relationships? So the kind of violence. So you're really looking for people that have been through any kind of physical violence, obviously. So physical violence includes slapping, hitting, pushing against a wall, choking, kicking, and more dangerous things are like burning. There's so many little things.
Right.
There's so many things that really is embedded in that term of physical violence. And then there's the obvious sexual violence. We know what sexual violence really does entail, whether it's rape or some kind of sexual coercion or anything of that nature. And then there's the mental abuse. And mental abuse is so variable. There's so much variation in it. And something that I was actually reading was that there's certain coercions that you can create, or a partner can create for their other partner, that encompasses abuse. And that includes even like limiting their financial spending so that they feel that they're powerless.
Right. It's like sort of a power, maintaining power.
Maintaining that power. I mean, that is how much, how important this topic is, because there's so many little things that's really, really, these are the details that we really need to know about. It's not just that physical abuse. It's the other kinds of abuse that we really need to screen for.
So I guess that two questions I have is,
Sure.
One, do you find that your patients are opening up to you about these issues? And two is, when they do, like, what do you do?
Sure. So that's a great question. The first thing is you have to build that rapport, like we were talking about. No one's going to tell you, oh yeah, I'm abused. No one's going to say that to you. You really need to know how to ask the question, like you were saying. And you have to get to it. You have to wait. You have to know when to ask. And building that rapport is super important. The way I ask it is I ask them point blank sometimes. Are you abused? Any kind of abuse? And usually, the answer is no. But sometimes the answer is yes. And you have to know then the next step is, what kind of abuse? Mental, sexual, physical, emotional. Are you emotionally being abused? Is someone insulting you all the time? Because insulting is also a form of abuse as well. Do you feel like when you're out with that person that they're always just making fun of you, or, that you just don't feel comfortable, that you feel embarrassed? All these things are important questions to ask, and you need to know how to ask them, and you have to be comfortable asking them. And that's another point, is a family physician or internal medicine or primary care in general, you have to be comfortable asking these questions.
Right.
You have to be. It's a part of your job. It's a part of our job to know what's going on in our patients' lives. I know that there are time constraints. We know that. I mean, the way that medicine works right now, we get, maybe 10, 15 minutes with a patient, really? Even in a 30-minute physical, after being vitaled and all that stuff, I get like 15, 20 minutes with the person. I have to go through the mammograms and the colonoscopies and all that stuff. So you have to make it a point. You have to go deep. And you really need to ask those uncomfortable questions because it is so important to know. It is so important that they feel like they have somebody that they can tell these things to. And I really feel like that is a part of our role. If not anything else, that is a huge part of primary care. It's a huge reason to be in the field. It's, so that's something that I feel like I really want to get out there. I really want my colleagues and medical students and residents to know that these are the kind of uncomfortable questions that you have to ask. And you have to, another point is, and I'm sure that you learned this when you were in medical school, is, when you're screening an adolescent for any kind of, alcohol use or tobacco use or whatever, you ask the parent to leave the room, right? We still do that. And it's the same when it comes to abuse questions. If you have a patient coming in for their physical and they're coming in with their partner, you can't ask in front of the partner. And you have to understand and sense the room. You have to sense if there's any tension or if there's any kind of over speaking, right? We need to see if somebody has more power in the room as well, right? I think that these are the things that you pick up on, which leads you to ask those questions as well. And it's easy to ask someone to walk out of the room. You know what? I have to ask a few personal questions. Do you mind stepping out for a sec? And usually the answer is okay. And then you ask them to step out. They go to the waiting room. And then you ask those uncomfortable questions. And you just hope that they feel comfortable enough to tell you the honest truth.
What are the guidelines exactly, though? Is this something that should be done on an annual basis at every visit? Is there a strict guideline or a recommendation for that?
So there's no strict guidelines, but the recommendations are there. So one recommendation in particular is about patients that are pregnant. So pregnant patients, 96% of patients that are pregnant receive prenatal care. That's a huge percentage. So what does that mean? They get 12 plus visits in that 9 to 10 month period, because we know that pregnancy is really 10 months, not 9 months.
True.
Anyway, so they get, say 12 plus visits. Every opportunity is an opportunity to ask if someone's being abused.
That's a particularly prevalent time for abuse also, isn't it, during pregnancy?
Right. So the statistics show that, I think I have the number here actually. Let me look for it for a sec. If we could just take a pause.
Yeah.
Nearly 1 in 6 pregnant women have been either abused or hurt by their partner in the United States.
That's a crazy high number.
That's crazy. And that's over 320,000 pregnant women per year.
Wow.
That is unbelievable. So if you see 6 women that are pregnant, 1 of them is being abused.
That's a crazy statistic. It's like,
so
wow.
And there's so many implications. So another thing that I was reading was that what are the side effects that happen to the patient if they're being abused, especially during pregnancy? Because this guideline, like I said, is for adolescent to 40-year-old women that are of the childbearing age. So it's patients that are prior to pregnancy, during pregnancy, postpartum. So what are the implications? And what happens to these women? Very, very detailed stuff that I was reading. And something that really got to me was, so not only do these women get these emotional and mental side effects, but it affects the babies. So how does it affect the baby? Preterm births, spontaneous abortions, and low birth weight babies are born from patients that are being physically or mentally or emotionally abused.
Makes sense, yeah.
It makes sense. And you know why more? Because a lot of these patients, when they're abused, they pick up other habits, whether it's alcohol, drug use, or smoking. And we know that smoking and drug use and alcohol use are risk factors for gestational hypertension, which in, I guess, layman's terms, is basically high blood pressure during pregnancy. And that high blood pressure during pregnancy can cause preterm birth, spontaneous abortions, and low birth weight babies. So that prenatal care visit is so vital.
Right.
It's so vital. We need to screen. And it's not just those visits. You see patients that are pregnant. I see patients that are pregnant. The patient comes in with the rash and she's pregnant. That's an opportunity.
Sure.
It's an opportunity for all of us because we all see these patients. And every visit is an opportunity to ask and to bring up the topic. As uncomfortable as it is, it's so important. And you're right. And another thing is that what do we do? I think you had asked me that earlier. There's a lot of social support, social services support that's out there.
So just like maybe if we can sort of specifically touch on it. Say I see a patient who's pregnant, has a rash, and I ask her the screening questions and identify that there's something, there's some sort of abuse going on, right? So what's the specific measure that I take at that point?
Okay, so first let's backtrack a little bit. Let's talk about the tools there's a couple of tools as well, and I didn't mention that earlier. I want to talk about those tools. So there are screening tools in place, and those are either printouts or acronyms that you can use. And one of them was, give me a second, a few of them. So one of the tools is called HARK, HARK, and that is humiliation, afraid, rape, kick, HARK. Another one is HITS, hurt, insult, threaten, scream. And there are more. There are more tools out there. These are the tools that physicians can use. And you just get familiar with them. Some of them are questionnaires, so you can ask the patient to fill something out. And even if it's, I think that an OB can have that a part of their, because we all have that paper that the patient fills out in the waiting room. And that's a screening tool that we can use, just like the depression screening tool that we use as a vital sign, right? Mm-hmm. We could teach our medical assistants to ask these questions, because our medical assistants, they put your patient in the room, they take their vitals, and then they screen them for depression. In my practice, at least, we do the PHQ-2, which is a depression screening tool that my medical assistant does, and that prompts me. So even if you just start with that, just a depression screening or one of these screening tools, it can prompt you to go further and ask those questions. And then the things that we do as physicians, as clinicians, is basically, first and foremost, we need to know what social support is out there, social service support that's out there. We need to know what's local, right? We need to know, I, for example, have case managers. I have social workers that I tend to refer to. The case managers are really important in this specific topic, because they're the ones that go further, and they're the ones that really find what service this patient needs.
So is this someone who works in your practice?
Yes, we have a caseworker.
So what if someone who's like a private practice? It sounds like where you are, there's like tons of resources, which is amazing for your patients.
Yes.
But for like that guy or gal who has their shingle hung up and has their own practice.
Yeah.
What do they do? Like, is there some government or like county person that you call?
So the first thing that you can do is called APS, the Adult
Protective Services.
Protective Services.
I didn't even know there was an Adult Protective Services.
Yes, there is. I have the number.
Okay.
I'll give it to you.
Yeah, that's great. Yeah, we should link it on the podcast. Yeah.
So, that's a really good question. You need to know what the sources are out there. So I think that the first thing that you can refer to is Adult Protective Services, and have the number on hand. You could Google it, anything like that. So, and the other.
So that's for anything really. Like
anything.
When any adult is in some sort of danger, you would call, just like a child, you'd call Child Protective Services.
Exactly.
Okay.
And they are the ones that provide the services. They will provide home visits. They will provide counseling. And under the Affordable Care Act, it's covered.
That's amazing.
No co-insurance, no co-pays. And you don't even have to meet your deductible. So these are the things that the federal government has put in place as well, because it's that important. Imagine if somebody that's of a lower socioeconomic status and they're being abused, they're afraid, what if this costs me money? Well, it depends on the Medicare, Medicaid situation as well. And when it comes to Affordable Care Act and under each private insurance that's there, they are required to provide those services, counseling, whatever it may take, at no charge to the patient. So that's a really big plus that we have in this country. And I think that, people really, really need to know that. We need to know you're right. We need to know what's available for our patients,
Right.
because we can't just blindly ask a question and then move on.
So one of the things that I've taken away from this is I honestly didn't know that there were, I mean, maybe it's because I'm not smart enough to know this, but I never knew there was an adult protective services.
Yeah.
And I think that's incredibly helpful to know, because
Yes.
I guess the biggest thing for me is, okay, if I identify an issue, like what am I going to do for my patient,
Yeah.
But so that's really, really helpful. I guess one of the other things that we should touch on is, which patients are at risk? Is there a certain demographic that's at risk? Is there a certain type of patient that's at risk? Who's at risk?
Sure. So like I said earlier, the guideline really does refer to women of childbearing age, and that's adolescents to 40s. However, the women that are people that are more at risk are younger women, people that have economic hardship, and they have marital difficulties. Those are really people that you should be screening a little bit more. And also I think I should say, the economic hardship, obviously. So lower socioeconomic status. That's a big one. I think, and also another one was people that have experienced some kind of violence as a child. And it's crazy, because who really asks that, So if somebody opens up to you about that, then it's a segue of asking those questions as well.
And obviously, when these things happen, there must be significant long-term effects for the patients. What are they, and what are measures that can be taken to sort of, treat those?
Sure. So long-term effects include, there are so many, aside from the immediate effects of injury, and whether it's an unwanted pregnancy or an STD, which also isn't a long-term effect. If you get an unwanted pregnancy, you have to decide what to do. That's a huge decision, especially as a young person. Or an STD, females that get STDs, they have difficulty. A lot of them can have difficulty with their reproduction later on in their life. So these are long-term effects as well. But the other effects are whether it's depression, anxiety, post-traumatic stress, alcohol abuse, tobacco use, or even drug use. So these are all things that are reasons. These are reasons that we really should be looking at the patient and asking them what's going on in their lives, because we can prevent it. It is preventable. Abuse is preventable. Although it's a hard topic to get into, it is so important that we do get into it, because it's preventable. We can prevent a death. We could prevent injury, long-term pain, long-term, or an unwanted pregnancy or an STD. These are all the things that are the reasons that I believe that it's so important to ask those questions.
I think one of the things you touched on earlier was sometimes this is sort of like a generational cycle of behavior that happens. Like if it happened to you,
Yes.
that particular individual may be more likely to either be abused or be abusive. If that cycle can be broken, I mean, that's like the whole point of.
And with the services that are there, they do the home services. So they see, what is happening in the house. What can we do to help these people in their relationships? And a lot of the interventions they even include financial support. They include support in the marital relationship, whether it's counseling or whatever it is. They educate on better communication skills. So these are the interventions that are in place. And after doing all these interventions, 76% of these interventions show one statistical significant benefit. So we know that any significant benefit is a reason to do that act. So we want to do the screening just for that one person, even if it's just one person that you can help. You want to screen, and it doesn't take a lot of time. It takes seconds to just ask those questions, and they're important. If not anything else, if you want to skip the mammogram question or the colonoscopy question, if you can, or if, they're not getting their flu shot that day, ask them the question.
Right. Yeah, I mean, that's a very encouraging statistic, actually.
Yeah.
Another statistic that you taught me today which is totally staggering, is every 9 seconds a woman is abused. Is that the right statistic?
So yeah, in the United States, every 9 seconds, a woman is either assaulted or beat.
Wow.
It's unbelievable. And 1.5 million women per year are either raped or assaulted in the United States. It's unbelievable. It's unbelievable. These numbers are crazy. And it's really sad, but we have to know what we can do. We have to know our role and how we can help our patients.
Well, I have to tell you, as heavy as this topic is and as hard as it is to talk about, I couldn't be more grateful to have you here to educate me and my audience. This is really important stuff, and it's going to make me a better doctor for sure.
Oh, so thank you so much for having me, and I'm so glad that we talked about it because it's so important to me, and I hope that I was able to help someone. I hope even if I don't know who your audience demographic is, whether it's just whether it's physicians or your patients, but if someone's listening and they have been through something, or if it's a physician that's listening and they said, you know what, let me start asking that question. Or if a patient's listening and they want to talk to their doctor, they're going to talk to their doctor. And doctors shouldn't be afraid to hear them. We should be open. We know there are resources out there, and it might not be the easiest thing to do, but it's why we practice medicine. We are out there to help people.
Couldn't have said it better. I'll just close by saying that your patients are very lucky to have you as their doctor.
Thank you so much.
Thanks
so
again.
are yours.
I appreciate that. Thank you very much. Thank you for listening to the Dr. Mudgil podcast. The audio for this podcast can be found on Apple's iTunes and SoundCloud. The corresponding video can be found on YouTube, IGTV, and Facebook. Let's get it.